Hello, and welcome to part 2 of the Bony Thorax lectures. In this lecture, we're going to begin with a few additional details about ribs and finish the lecture with some details about positioning for the sternum. So let's get started. First, again, let's talk about a few more details that I need you to know about the ribs. So each rib has two ends, of course, a posterior end or vertebral end, and you can imagine that articulates with the vertebral body of the spine, and an anterior or sternal end. And of course, that end articulates with the costocartilage and then the sternum. Between the two ends is a shaft or body of the rib, okay, just like any other long bone. The vertebral end consists of a head, which articulates with one or two thoracic vertebral bodies, and then a flattened neck. Lateral to the neck is an elevated tubercle that articulates with the transverse process of a vertebrae, and it allows for attachment of a certain ligament, which we don't need to know. Think about this. What other bone in our body has a head, neck, and tubercle? Did you say the radius? Yes, exactly. Okay, so the body of the rib extends laterally from the tubercle and then angles forward and downward. And the area of forward angulation is termed the angle of the rib. Okay? Looking at the rib from the posterior aspect, there's a few additional details I want you to know. So remember, the angle of the rib is the part at which the body or the shaft curves forward and downward towards the sternal end. So let's orientate ourselves. Here is the vertebral end, right here, that attaches to the vertebral body posteriorly, and here is the sternal end that attaches to the costocartilage and then the sternum. Notice that the posterior or vertebral end of the rib is typically 3 to 5 inches higher than the anterior or sternal end. It's kind of a lot, so just keep that in mind. The rib really does angle downward at this region of the angle. The lower inside margin of each rib protects an artery, a vein, and a nerve. And you can see that right here, this groove, the costal groove. Therefore, rib injuries are very painful and may be associated with substantial hemorrhage or bleeding. Again, that inside margin that contains the blood vessels and nerves we call the costal groove. So here is a diagram of the bony thorax without the sternum and without the costocartilage. And the fifth rib has been highlighted in blue to demonstrate that real downward angulation of the ribs. Notice that not all of the ribs look the same. The first few ribs are short and broad and are the most vertical of all of the ribs, meaning they really point downward. As you go further down the rib cage, the ribs get longer and longer down to the seventh rib. From the seventh ribs down, they once again get shorter and shorter through the fairly short 12th rib, or the last pair of ribs. The first ribs are the most sharply curved, and the bony thorax is typically widest at the lateral margin of the 8th or 9th rib. So in other words, our thorax is the widest at the 8th or 9th rib. The ribs get longer and longer down to the 7th rib, and then they begin to shorten again. So next, let's talk about the articulations or the joints of the bony thorax. And I don't need you to memorize the joint classifications here, so you don't need to write down every detail, but I just want to kind of introduce these concepts to you. So let's talk about A. A is the joint between the costocartilage and the sternal end of the fourth rib. So where the costocartilage meets the rib is called a costochondral union. And ribs 1 through 10 form a unique type of union where the cartilage and the bone are bound together by the periosteum of the bone itself. And this permits no motion. Therefore, they're classified as synarthroidal. So all of these costochondral joints are very tightly bound and there's no movement there. Okay, B is the sternoclavicular joint, or the SC joint, and of course you have one on each side. The SC joints are synovial. They contain articular capsules that permit a plane or gliding type motion and therefore are considered diarthroidal. C is the sternocostal joint of the first rib. So where the sternum meets the costocartilage, okay? The cartilage of the first rib attaches directly to the manubrium with no synovial capsule and therefore allows no motion. So they are synarthroidal. Therefore, the sternocostal joint is a cartilaginous joint of the synchondrosis type. And again, I don't need you to know that, okay? Okay, D is pointing to the fourth sternocostal joint, which is typical of the 2nd through the 7th joints between the costocartilage and the sternum. These, in the lower ribs, are synovial joints, which allow a slight plane or gliding motion, making them diarthroidal. So again, the first sternocostal joint is synarthroidal, but as you go lower through the rib cage, the 2nd through the 7th ribs, those sternocostal joints are synovial and allow for slight gliding or plane motion, making them diarthroidal. So kind of interesting. Different sternocostal articulations have different joint classifications. Okay, E is referring to the continuous borders of the interchondral joints. So the joints in between the costocartilage of the anterior 6th through 9th ribs. And they're all interconnected by a synovial type of joint with a thin, long articular capsule lined by synovial membranes. Well, guess what? If it's a synovial type joint, it allows for movement. So these interchondral joints have plane or gliding motion and are therefore diarthroidal. And that helps facilitate movement of the bony thorax during the breathing process. Expansion and contraction, of course. The interchondral joints between the 9th and the 10 cartilages are not synovial and are classified as fibrous syndesmosis. Again, you don't need to know that. So really the takeaway here is that the different articulations throughout the rib cage have different classifications. Some allow for movement, some don't, and again, that's helpful in breathing. Okay, a couple more things to discuss before we conclude. The remaining joints that are found within the bony thorax are posterior. And think about where the rib articulates with the vertebrae, okay? So the costotransverse joints, which is F. So that is where the transverse process of the vertebrae is meeting the tubercle of the rib. These are synovial joints with articular capsules lined by a synovial membrane. Therefore, they allow some movement, so they are classified as plane or gliding and diarthroidal. Okay. Costovertebral joints, which is G, remember that's where the head of the rib articulates with the body of the vertebrae, are also synovial, diarthroidal, and allow plane or gliding motion. Costotransverse joints, remember, are found on the 1st through the 10th rib. The 11th and the 12th rib, remember, lack this joint. So the 11th and 12th rib do not have the costotransverse joint. The costovertebral joint, of course, is present in all 12 ribs. Okay, now all of this information is summarized for you in a chart in your textbook. but I need you to know the difference between the costotransverse joints and the costovertebral joints. Okay? All right. Here is an x-ray of a sternum. So we're going to wrap up our discussion looking at the sternum. I just want to point out the sternum to you. So here is the manubrium. Here is the body, and here is the xiphoid. The sternum is kind of a cool looking bone. Here is sternal angle where the manubrium meets the body. Okay, of course you have the sternoclavicular joints up here. And this x-ray is taken with the patient in a slight oblique, and the purpose is to throw that sternum away from the spine so that we can visualize it. So let's talk about that next. It is impossible to visualize the sternum in an AP or PA position because it is such a thin bone and it's superimposed with the much denser thoracic spine. Therefore, to visualize the sternum, we must rotate the patient in a 15 to 20 degree anterior oblique position. And again, that shifts the sternum to the left of the thoracic spine and into the shadow of the heart. Well, what's the benefit of that? Because it's such a thin bone, if you put it in front of a thicker heart muscle, it helps with added density. It helps to visualize that thin bone better. The degree of obliquity required is dependent on the size of the thoracic cavity, and that's what we see demonstrated here in these pictures. A patient with a shallow or thin chest, which you see here on the right, requires more rotation than a patient with a deep chest. And again, the purpose is to cast the sternum away from the thoracic spine. So a large barrel-chested person typically requires closer to 15 degrees obliquity, while a thin-chested patient needs more, like 20 degrees. So let's look at these for a second. This is posterior, this is anterior. Here is the sternum right here, this little blip of bone. Notice now it is projected away from the spine and kind of over the heart muscle. And again, that added density of the heart muscle helps us to visualize that sternum better away from the spine. So here, again, a larger patient needs less obliquity than a thinner patient. Okay. So in addition to rotating the patients into a slight anterior oblique, a breathing technique may also be used for radiographs of the sternum. And the breathing technique involves the patient taking short, shallow breaths during the exposure. Do you remember what that's called? We used that breathing technique when we imaged the scapula. Remember, it's called an orthostatic breathing technique. If performed properly, the lung markings that are overlying the sternum will become obscured and the sternum will be sharp and well defined. For a true orthostatic breathing technique, you should use a low KVP, a low MA, and a long exposure time, like 2 to 3 seconds. Okay, so of course, we'll take a closer look at this when we meet in lab. If you have any questions at all, please let me know. Thank you.